Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing another really fascinating guest for you today involved in science and technology and biomedicine, creating a better tomorrow for millions of patients out there. As a little background to today's show, for pretty much the last 30 years or so, the area of small cell lung cancer has remained one of the most challenging, aggressive, and difficult to treat cancers. It's marked by rapid progression, high relapse rates, very few meaningful advances. But that may be finally starting to change. And today we have the honor of being joined by Dr. Angela Coxon, who is Vice President of Research and Development at Amgen, where she leads development of next generation therapies aimed at tackling exactly these types of challenges. And her work spans everything from discovery research, translational medicine, molecular oncology, ultimately bridging the gap between early scientific insight and real world impact for patients. And if you've been following the show, you may remember about a year or so ago our conversation with Dr. Ryan Potts from Amgen, where he introduced this concept of induced proximity to us, where instead of simply blocking certain areas of biology, instead thinking about designing drugs that ultimately bring components of biology together to create entirely new functions. And that is the idea that's playing out in the clinic now through approaches like so-called bispecific T-cell engagers, which ultimately physically link cancers to immune cells and ultimately force targeted immune responses to go after tumors. Dr. Coxon earned her PhD in molecular biology from Oxford, went on to complete postdoc training in vascular biology at Harvard Medical School, Brigham Women's Hospital, and just built a career around this important intersection of cutting-edge biology and strategic drug development, contributing to Amgen's pipeline. And we're very honored to have with us. That being said, Dr. Angela Coxon, welcome to the show.
Thank you for having me. What a pleasure to be here.
No, it's great having you. A very important topic, and I would love to just start off by going right into the topic of small cell lung cancer. This is one that we haven't touched as much about as other cancers, but we have something that's extremely aggressive, very high relapse rates, as I was mentioning, and comes with some very unique challenges in terms of being somewhat undruggable, in terms of targets, being a cold type of tumor that the traditional immune responses don't always work too well in. Take us down the landscape of sort of the pre-Imdelltra small cell lung cancer world before we jump into where we're going with our discussion today.
Yes, well, how you described it was very accurate. So lung cancer can be split into small cell and non-small cell. And small cell is about 15% of the total population. And worldwide, that represents a very high unmet need. It's about 2.4 million cases every year. How you described it is very accurate. Most patients, when they're diagnosed, have extensive stage disease. And so it's already disseminated, and it's a disease that's characterized by this highly disseminated disease. At the time of diagnosis, most patients go on chemotherapy, and they initially respond to the chemotherapy. But unfortunately, those platinum-based therapeutics don't give them a durable response. And after a very short period of time, they go on to relapse. And so the 5-year overall survival rate for small cell lung cancer is less than 10%. It really is a grievous disease with a very high unmet need.
Along those lines, and specifically, this gets us close to, the principle of how Imdelltra was created. And as mentioned, we talked a little bit on previous episodes about this principle of induced proximity, and we'll be getting into sort of what a bispecific T-cell engager actually is. But this approach, and we'll talk about the targets in a minute, is a little more than sort of some of the traditional immuno-oncology that we think of, that we're going to take a checkpoint off, or we're going to induce put a CAR T-cell into somebody. Doing something very different here. And I wonder if you could talk a little bit about the principle of forcing an immune kill, because it's very different than other immuno-oncology concepts that we've talked about. And then we'll talk about how you're doing it.
Yes, it is different. And I like the way that you described it, of this sort of forced, targeted immune therapy. So the way that these molecules work, where you described it was a bispecific T-cell engager, they have two arms, and one arm of the bispecific binds to the immune cell, in this case the T-cell, and the other arm of the bispecific antibody binds to the cancer cell. And it binds to a molecule on the cell surface that's a very specific receptor. And so it's a very accurate, deliberate way of bringing the immune cells into close proximity with the cancer cells. And by doing that, it forms what's called a cytolytic synapse. And it means that the cancer cells are killed quite potently. What happens then is the T cells become activated. They go on to proliferate, so more and more T cells, and they go on to kill more and more cancer cells. It's a very potent mechanism of cell killing, and one that we have embraced at Amgen very well since we acquired a company called Micromet.
And in this particular case of Imdeltra, the two targets that we're talking about here, one is known as DLL3, and this is it stands for delta like ligand 3, which is not just found on small cell lung cancer, but it can be found in other tissues as well. We'll get into that a little later on when we talk about looking beyond small cell lung cancer. But so here is an entirely new target in terms of our T-cell. We're talking about a target known as CD3, which is a component of T cells, but once we activate, it doesn't entirely activate it until it meets up with the cancer cell. So nothing's happening until this magic of here's our cancer cell, here's our T cell, let's bring them together and do our magic. Could you just say a couple words again about, a little bit about this forced synapse, because this is a really elegant, let's say, way of thinking about the biology here and what's happening, as Ryan talked about last year, in terms of creating this important therapeutic bridge between cells.
It is. It's a really sort of very clever way of forcing the immune system to attack the cancer cells. And the target selection, to me at least, is paramount. You really have to have the right molecule that's expressed on the cancer cell surface so that you engage the immune system in the right way and only kill the cells that you want to kill. As I mentioned, we found it to be a very potent mechanism of cell killing. You need the cytolytic synapse to form, and it only forms when you get the close proximity of the tumor cell with the T cell. And I think what's so promising about this type of therapy is that it doesn't come with the side effects that we're so familiar with chemotherapy. Using the patient's own immune system to engage, that's why we call it a bispecific T-cell engager, it comes with fewer side effects than things like chemotherapy.
Excellent. So again, something for our audience, we have the ability to go around sort of the druggability issue. We have the ability to work in relapse disease and the turning the sort of the cold tumor hot, and ultimately the ability for multiple tumor cells to be killed by one T cell. Let's then go into the world of Imdeltra, because the product was recently approved last year. It came out of a rather large phase 3 study in patients with extensive stage small cell lung cancer. I think used after a second line after platinum therapeutics. Take a little time again to walk through what happened in this study, because this wasn't a single arm. This was a true randomized comparison versus another standard of care, and a lot of really, probably in terms of 40% reduction in risk of death, quite startling results leading to its approval. And take a little time with this, if you would, Angela.
Yeah, before I do that, let me tell you a little bit about the target because it will play into what we believe why we saw such compelling data in the phase 3 trial. So DLL3, as you mentioned, delta-like ligand 3, is expressed on the cell surface of almost all patients with small cell lung cancer. We think it's certainly greater than 90% of patients. And what's really important is that although it's expressed widely in the patient tumor cells, it's not expressed on the normal tissues. And so that allows us to have what we call a big therapeutic window, a good safety margin in the clinic. And so when we moved the molecule into clinical testing, we were able to see responses, but also the molecule was well tolerated in the clinic. And we think that's driven because of this very clean expression profile of the target. So you referred to the phase 3 trial results that were released last year, and very exciting data there. I mean, really, it was in the second line setting, as you mentioned, so patients that had been treated with a platinum-based chemotherapy. And it was the first trial of this patient population to show an overall survival benefit in this setting. So really very, very exciting results for patients with extensive stage small cell lung cancer. The overall survival benefit was greater than 5 months in this setting. And so, and more than, I think, roughly 40% of patients responded to therapy. So very promising results. This was a monotherapy trial. So Imdeltra is given as a standalone therapy. And we've compared it to the standard of care chemotherapy and found a significant improvement in survival.
And the survival benefit, when you look, they looked at the subgroup, benefited patients that had, platinum-resistant disease, benefited patients that had prior checkpoint inhibitors. So really, I mean, it did extremely well. Can you say a couple words? Because I know people always look at, obviously overall survival, and then there's also the progression-free survival numbers, which always diverge a little bit. But in this particular case, the interesting thing is, aside from having responders with extremely durable benefit, what did you learn in terms of the immune-mediated side of this? Obviously, you're forcing the kill, but in terms of these bispecifics that, have the ability to impact the immune system sort of beyond the initial kill process. Any interesting insight there when you sort of drilled down on some of these patients that lived a lot longer in the trial?
Yeah, we're still doing a lot of analysis in that space, but what you're touching on is something I think is really important, and it's the durability of response in some of these patients. And we've seen the same with other types of immunotherapy, but not in small cell lung cancer. And so I think we're really encouraged by what we've seen here, that some of these responses are extremely durable. The same has been true with some of our other T-cell engager programs, like blinatumomab. And so I think there's something there that's very compelling. As I mentioned, you can get durable responses. The side effect profile isn't very unmanageable. And so very encouraging data. We're trying to understand a bit more around what determines response. And so we're looking at things like numbers of T cells in the tumor, what is the host immune system like when we treat the patients? Could the target expression help determine which patients respond and which ones don't? But that's very much a work in progress.
Got it. But ultimately, clear survival benefit, novel mechanism, major advance over the decade. This is not just another therapeutic in the small cell lung cancer portfolio. That being said, what comes next? So clearly, this led to approval, but clearly, in terms of frontline therapy, in terms of combination bispecifics with other agents like checkpoint inhibitors, how do you think about sort of what comes next when we specifically look at small cell lung cancer? We'll talk about other cancers in a minute, but where do you go next with this? Because clearly amazing work, but a lot more to learn about.
Yes, exactly right. So of course we want to move into earlier lines of setting. as we've earlier lines of treatment. As we've talked about, right, the trial that led to the full approval was the second line setting with extensive stage disease, and it was monotherapy. And so, in fact, late last year, we released data for the first of those phase 1 trials where we had combined Imdelltra with an anti-PD-L1 antibody, which is a checkpoint inhibitor therapy that's been approved in small cell lung cancer, and saw very, very encouraging results there. Now, in the analysis that we did, the overall survival had extended even further. And so, I mean, I'm a firm believer that the way to reach durable responses in cancer is through combination approaches. And the first of those data that we've looked at has been the combination with the anti-PD-L1 antibodies. We're exploring other combinations, things that might improve the tumor environment for, tumors are considered to have what's referred to as an immunosuppressive environment. And so anything that can get over that, any other kind of orthogonal mechanism, we're very interested in exploring combination therapy. And again, moving up into earlier lines of treatment so that more patients can benefit from this truly innovative therapy.
Another interesting thing I noticed, when Imdelltra was approved, it went through sort of the FDA's sort of real-time oncology review, which enhanced the speed, which is extremely important. It's just funny, we're talking at a time, just because I think just yesterday, the commissioner of FDA announced sort of this new real-world, real-time setting study model, and Amgen was involved. There's something called Stream Small Cell Lung Cancer. I wasn't sure if that's an Imdelltra project or if that's something else, but I'd love to just hear just a couple words about sort of the enhanced approval of these agents, because it's an extremely important piece of time and saving lives along with the development process.
Ira, you're touching on something that's very close to my heart. I've had the chance to meet with some of the patients that have been treated with Imdelltra, and they have talked about how they see the time going so fast in front of them. And so every week counts for them. They can't get these medicines fast enough. And so the accelerated approval process that you're talking about with the FDA, I think it's a wonderful thing because it's bringing these medicines to patients faster than ever before. And they are literally waiting week after week for these new medicines to be approved. So very happy to be a part of it, and happy that Imdelltra was able to be one of the groundbreaking products there.
Excellent. Excellent. Angela, can you talk a little bit, maybe beyond small cell lung cancer? Because, I was reading a little bit, sort of getting up to speed on DLL3 before we chatted, and it seems to, obviously, it's found in small cell lung cancer, but it's also mentioned in certain prostate cancers, other types of neuroendocrine tumors. What is sort of your vision in terms of the possibilities there? Because clearly it's shown amazing potential in this extremely difficult to treat cancer. Where else potentially do you see application in the portfolio?
Yeah, you're right. DLL3 is expressed in some other tumor types. It's not as robust as it is in small cell. As I mentioned, in small cell, DLL3 expression is almost like a characteristic of the disease. And so we're working through that. It's early stages now to understand whether Imdelltra could have an impact in other settings. I think, the T-cell engager therapies, it would be wonderful to bring those into other tumor types. We've seen the promise in heme malignancies. There are now 10 different T-cell engagers that are approved on the market, but only 2 of them are in the solid tumor setting. And so at Amgen, we've been looking at other targets that might be expressed, and we have products in our pipeline that are T-cell engagers that go after different targets for, say, prostate cancer. So I find it a very exciting and elegant new way of treating cancer.
It's such an exciting time, and I took a look at your PhD. Went back in the literature, and it's so interesting because you started off studying some of these mechanisms of cell cycle in yeast. It went on to vascular biology, and thinking about metastasis and the tumor microenvironment, and now here we are with these really unique bispecifics. What else excites? I mean, just thinking about the future here and looking a little over the horizon. What other areas? Because clearly you spent a lot of time in oncology. You know the area extremely well. What else gets you excited in terms of looking out 2030, 2035? What are the hot things that you think about? Keep you up at night about thinking about these new opportunities for patients?
Oh, what a great question. I mean, I feel very lucky to have spent my career in oncology research over the past 2 decades. It has changed so much from when I first started. When I first went to, the big cancer meeting, AACR, it was all about chemotherapy. And
Yeah.
we've talked about all of the limitations of that. And over the past 2 decades, I mean, several different types of cancer, the landscape has been completely transformed. And it's been transformed by this revolution that we've seen in immunotherapy and also this revolution in targeted therapy. And we haven't talked much about non-small cell lung cancer on the call today, the other type of lung cancer. That has been characterized really by targeted therapies and by immunotherapy. And it's really had a huge impact there. Small cell is interesting because it doesn't have that same flavor of the targeted therapies. They haven't worked there, those sort of molecularly targeted therapies. So what else is on the horizon? I mean, I think, Amgen was one of the pioneers in the KRAS space. There's more to come there. The first inhibitors targeted the G12C mutation, and now we're looking beyond that single mutation. I think synthetic lethality is a really interesting mechanism of action. Again, should have a much bigger therapeutic window than chemotherapy. And I think there's a lot more to come from immunotherapy, especially in the T-cell engager world. As I mentioned, we've only had 2 approved in solid tumors. So I think there's a lot more to come there.
Excellent. Excellent. And then just, could you just say a few words while we have you about what's coming up for you? Because I think you just got back from AACR, and you were talking about innovative treatment modalities there in Houston, I believe. I don't know where it was located.
San
But
Diego.
San Diego, right, right, right. Where else can we find you in the coming months? Scientific conferences, other talks that you may be giving that are public facing, and then anything else while we have you today that I did not touch on, please.
Well, thank you, Ira. Yeah, I had the pleasure of giving a plenary presentation at AACR, and it was all around T-cell engagers and the impact they've had, and 4 clinical stage programs that are moving forward. Yesterday, I gave a plenary presentation that was virtual. Luckily, it was in Korea for the Bio Korea conference. There's so much going on in the space of biotechnology. There's so much innovation going on. Let's see, what else do I have coming up on the horizon? Of course, we have ASCO coming up.
Yep.
I will see
Sure.
more clinical data released. Very exciting. Like I said, I feel very lucky to have spent my career over the past 2 decades in oncology research. We've made such a difference, and it's really been such a pleasure for me to meet some of the patients where we've had an impact. Who can ask for more as a scientist?
Absolutely, absolutely, and you see it happening in real time. So,
Yeah.
no, it's extremely impressive. I look forward to, again, I'm rooting you on and continue to follow you and your team with as you bring out these new therapeutics in the coming years. But extremely impressive work. Again, for everybody out there that is going to be listening to this episode across the various podcast networks, or who will be watching on the YouTube channel. Again, you've been spending time with Dr. Angela Coxon, Vice President R&D at Amgen, doing really amazing work to develop these novel therapeutics for these areas of significant unmet medical need in oncology. Angela, again, I want to thank you for taking the time out of your your schedule today to come talk to us for a little while about this very important program or set of programs. Obviously, thank you for everything you do there for patients at Amgen. As we like to say here on our show, thanks for helping to create a better tomorrow for literally millions of people via championing these types of programs. Really a great story, and I look forward to continue to follow you.
It has been my honor.
Really wonderful having you.